Okay, everyone, we're going to start the emergency medicine section. We're going to start with the first case. We're going to go through the chief complaints, history, and physicals, and I'll generate questions as we go along. All right, and we're also going to, as a thinking exercise as we go through some of these cases, introduce questions as we go along that will help you think along the lines of the CSA, the computer simulated assessment part of the exam. So I'll be asking you, what would you do now, rather than which of the following would you pick? Okay? Now, as we go through the cases, I'm going to be generating multiple choice questions also for you to stop while you're watching the video and try and answer. Okay? So, first case. Patient says, "Leave me alone." Very popular chief complaint. A 64-year-old man with a history of chronic alcoholism is brought to the emergency room department by the police, who found him agitated, combative, and shouting at imaginary monsters. Vital signs are temperature 39, 102.2, blood pressure 130/85, pulse of 110, and respiratory rate of 24. Now, we have a CSA tape on step 3, which hopefully you guys have had a chance to watch. If not, what you'll do when you do watch is you'll see that as I go through the CSA tape and sort of give you a strategy to get through it, we talk about asking the question very early on in the case, is this patient sick or not so sick? Is this an acute patient that I need to start doing something therapeutic or diagnostic right away? Or is this a patient that I could wait and get more information, do some diagnostic tests? So is this patient sick or not sick? Is this patient acute or not acute? A patient like this obviously is acute. All right? He's febrile, he's tachycardic, he's combative, he's tachypneic. Obviously, this is a patient that I'm going to have a heightened level of suspicion that I better start doing things right away if it's a CSA case, rather than taking lots and lots of history, looking for lots and lots of exotic tests. So let's get back to this case. The patient appears disheveled, agitated, and is sweating profusely. He is staring around. Examination of the head, eyes, ears, nose, and throat shows poor dentition, supple neck, and intact cranial nerves. Cardiovascular examination shows tachycardia with no rubs or gallops. His lungs are clear. His abdomen is benign. There is no clubbing, cyanosis, or edema of the extremities, although there is a resting tremor of the hands. Neurologic examination is non-focal, and there is no evidence of external injury. Now, a question that the boards might ask you on step 3 might be, what would be your next step in management? And they'll say, CAT scan of the head, place an intravenous solution, do a stool guaiac, chest x-ray, or abdominal CAT scan. Obviously, the answer here will be put an intravenous line. Sometimes the simplest thing, although it might sound very too simple to be the right answer, is the right answer. Obviously, you're going to think about doing a CAT scan in this fellow. He's an alcoholic probably. You might think about pancreatitis, etc., etc., etc. All of those things are popping into your head, but the question will say, what is the first diagnostic step, the first step you will take, or the next step you will take, is to establish IV access, because you know that you need to perhaps give this man something right away intravenously. All right? So the simple things are often very important to do as the first thing. And certainly if this was a CSA, and if you ordered a CAT scan first, you're going to lose a lot of points for that. And the way I like to think about it in terms of practicing for the CSA, and of course the CD-ROM that you have doesn't grade you, doesn't give you your scores, but in general the way I like to think about it is the following. You could do good things to the patient for which you'll gain points, and you could do bad things for the patient for which you'll lose points as they calculate your score in their secretive, mysterious way at the people who make your USMLE. But I like to think of it in terms of when we do these exercises as good things for the patients. I score as +1 point, +3 points, or +5 points. Obviously, the really important things that you do, you'll get 5 points. If it's something that a little benefit for the patient, we'll call it +1, intermediate +3, and the same for the bad things. For instance, if in this patient I say drill a burr hole into his skull to relieve pressure, that's going to be -5. Okay? Now, sometimes drilling a burr hole in someone's head will be +5, but obviously you need to know how you would prioritize what you're going to do. And think of it, what you would do if you're actually sitting there with the patient in front of you. And if something sounds too simple to be the answer, sometimes that's exactly the case. It is the answer. Okay? For the instance of this fellow, I'd put an intravenous. All right? And that would be +5. Okay? Now, let's ask you a question. What is the most likely diagnosis in this case? Is it delirium tremens? Is it Wernicke's encephalopathy? Is it schizophrenia, meningitis? Some of these choices are here, etc., etc. What will fit best for this patient? Delirium tremens. Okay, this is a pretty classic example of a patient who has alcohol withdrawal. All right. Now, as I went through the question, as I'm reading this question on the exam, what should have pointed me in that direction? Well, the first sentence, we're told he has chronic alcoholism. And he's agitated, combative, shouting at imaginary monsters. So shouting, I mean, he's seeing things that aren't there. He's having visual hallucinations. That one sentence, the first sentence of the case, really gives you all the information you need. Now, can this man also have a subdural hematoma? Sure. Can he have some superimposed infection on top of his withdrawal? You know, after all, he's alcoholic, he's fallen asleep, maybe he's aspirating, etc., etc. Yes. But again, the most likely and most important diagnosis to make in this question is delirium tremens. Let's look at what tests were ordered, and let's say this is still, we're reading through the question, and imagine that you're on the USMLE, and now you're getting this information either in a multiple choice format, and this is still part of the question, or in the CSA. And you're given electrolytes, sodium 146, chloride 108, BUN 30, creatinine 1.3. Anything there remarkable to you? Now, let's say this was CSA. After you put in your IV, there are going to be things that we'll talk about in a few minutes about what you do for your patient with DT, delirium tremens, and I'll refer to it now as the DTs. But getting electrolytes will be one of the things you do. And you'll probably get, at this point, you put an IV in and you send off electrolytes, you'll probably get +1, +3. Now you'll say, well, don't I want to give him some medication before I get the electrolytes, just to make sure he stabilizes? Yes, we'll talk about what you could give him intravenously to see if that helps, and you can get points for that. CSA allows you many different options as long as they're reasonable to gain points. Whereas multiple choice, obviously, you're going to have to pick the one most important thing. For instance, if this patient, if the question was the stem that I gave you, and then I said, what is the first step in the evaluation and management of this patient, and besides the choices I gave you, I said, draw serum electrolytes, you might say, yes, that's very important. I want to make sure he's not hypoglycemic. I want to make sure lots of different possibilities that might be indicated by the electrolytes. But again, would I do that before I put in the IV? The answer is no. Always establish intravenous access in an acute patient. All right? And in real life, you're probably doing both at once. You're putting in the IV, you're drawing bloods from the catheter, maybe you're putting it in the IV, someone else is drawing bloods. But in reality, stop and think is, which test do I need, or which procedure do I need first? Which is the most important? And that's an important part of step 3, is being very specific about how you prioritize in what you do for the patient. So what do we see in these electrolytes? Anything remarkable? Well, BUN and creatinine of 30 over 1.3. What does that suggest to you? That he is intravascularly depleted, that he has some pre-renal condition. Why do I say that? What is it about the BUN and creatinine that tells me that? It's the ratio of greater than 20 to 1. The BUN is more than 20 times the creatinine, and it indicates some pre-renal state. It could be hypovolemia, which is probably the case here. In other patients, it might be congestive heart failure with poor forward flow. It might be renal artery stenosis with flow having trouble to get through into the kidney. But whatever etiology, it is a pre-renal etiology, and by far the most common is hypovolemia. We get a alcohol level, and it's 0. We say, well, maybe this guy's just plain drunk. That's a very good thought. From the first line, or even the first paragraph, I don't know that this guy's withdrawing or he's actually drunk. Okay? Now, do drunk patients get combative? Absolutely. Do drunk patients hallucinate? Not usually. All right? I mean, that makes me think that this is more of a withdrawal syndrome with DT rather than a patient who's just drunk. All right? But I get the alcohol level with the electrolytes, and it's 0, which is consistent with what my hypothesis is, that my diagnosis is DT, that the patient drank, stopped drinking, and is now having a withdrawal syndrome. We check a magnesium level, and as you see, it's quite low, which is often present in patients with DT. We get an arterial blood gas, and let's look at that. pH 7.46, PCO2 32, PO2 84, and the serum bicarb is 24, O2 saturation 96%. So what kind of acid-base disturbance is this? 746, 32, 84. pH 746, PCO2 is what? 32, I said? And PO2 is 84. All right, so we look at this. Is acidemic or alkalemic? This is alkalemia. Okay. And why is it? Is it respiratory or metabolic? It's respiratory. This number is 32. 40 is normal. And in fact, we're told the serum bicarb was 24. Okay. Now, this PCO2 means the patient is hyperventilating. That's all you know. Hyperventilation does not mean anxiety. It does not mean pneumonia. It does not mean anything other than the patient's PCO2 is lower than it should be. Okay? That is a strict physiologic definition of ventilation. Ventilation is determined by your PCO2. If you're hypoventilating, I could tell you the PCO2 is above 40. If you're hyperventilating, for whatever reason, your PCO2 will be lower than it should be. Okay? Now, why does this patient have a respiratory alkalosis? Well, he's agitated, he's hyperventilating, it's part of his sympathetic state, as we'll talk about in a patient with delirium tremens. So here we have a patient who has a respiratory alkalosis, all right? And it's pretty acute, so you know the metabolic compensation for any respiratory process takes a number of hours or even days. So you haven't really seen much of a compensation yet, okay, in the serum bicarb. But you'd expect the serum bicarb to fall if the patient remains persistently alkalemic with a high pH. It hasn't had a chance to do so yet because presumably this is a very acute event. Secondly, this patient is dehydrated, which tends to raise the serum bicarbonate anyway. So you have two reasons why the bicarbonate is still in the normal level. One, it hasn't had a chance to fall. Number two, there's actually some cause for it to be higher than it should be, namely the patient is volume depleted. Okay, so we've gone through the blood gas here. Oxygen saturation is 96%. Now, is that a normal blood gas in terms of that patient's pulmonary status? We said the patient's hyperventilating. We know that from the PCO2. You look at the PO2, and it's 84 millimeters of mercury. We say that's not bad. It's 96%. But that's not the way to determine patient's pulmonary status. A much more accurate measure is the measurement of the alveolar arterial gradient, the AA gradient. And we could calculate that here because let's say this question, the patient then develops the next day a fever and a cough with productive sputum. Obviously, you're worried that the patient's had an aspiration pneumonia. So let's talk about what this patient's baseline AA gradient is. So we calculate it as follows. The alveolar the gradient between these two. The arterial we're given. That's 84. To get the alveolar, we do 150 minus 1.2 the PCO2. And this formula holds for patients on room air. And this PCO2 is 32. 0.2 is a fifth. So a fifth of 32 is 6. So 1.2 is 32 plus 6 is about 38. Okay? You don't need a calculator for this. Minus 38 equals 112. The gradient is the alveolar minus the arterial. So 112 minus 84, 28. Normal should be about 10. Okay? Now, I don't know if this man's AA gradient is usually in the 20s, almost 30. But certainly this is not normal. Okay? Many alcoholics are also smokers, so maybe this is his baseline. Or maybe I'm starting to think right away, did this man already aspirate? Because this is not a normal AA gradient. Okay? So let's go back to the case. We do the blood gas we did. We do a CAT scan of the head. Why would we do a CAT scan of the head somewhere along the way here? Somewhere along the way, an alcoholic who's combative might have changes in mental status coming up as part of the case. What am I looking for in the head? Am I looking for a brain tumor? Am I looking for a subarachnoid hemorrhage? No. I'm looking for subdural hematoma. Maybe this guy, while he was drunk, fell, maybe got into a fight with the cops bringing him in, got hit over the head, and now has a subdural hematoma. All right? And there, I would expect to see waxing and waning mental status. without focal neurologic findings. All right, does this patient have focal neurologic findings? No. All right, there's no evidence of external injury, no evidence of trauma. Do you need evidence of trauma to have a subdural hematoma? In other words, could you have a subdural hematoma and have no external evidence of trauma? Sure. But it helps if they told you there's a big gash on his head. Obviously, they want you to think that he had some trauma to the head. But this fellow has not had bleeding inside his head, and that's reasonable to do. If you did a head CAT scan on the CSA part of the exam before an IV, I would say it's -5. Because you're sending the patient off to some part of the hospital, the radiology department, it's dark in there. Who's watching the patient? The patient's not being monitored. First, stabilize the patient before you send the patient. Is a CAT scan appropriate? Yes. Should it be the first step in the management? No. You do a lumbar puncture. Well, why would you do that? Why would you take a needle, stick it into this guy's lumbar spinal canal, suck some fluid out, send it to the laboratory? Why would you do that to this poor fellow? Because he is febrile, he's had an acute change in mental status, presumably, and you want to rule out the possibility of bacterial meningitis. Would I have done a spinal tap in this patient? Absolutely not. All right? Now you say, well, aren't alcoholics at risk, increased risk of infections, and maybe he has pneumococcal sepsis because he aspirated and the pneumococcus went from his lung to his brain, his meningitis. Yeah, it's possible. Is it likely? No. I have another very good explanation. All right? If I treated the patient for DT and he didn't respond promptly, I'd say, yes, sure, you must do a spinal tap. First, I would do the CAT scan, make sure there's no collection of blood causing increased intracranial pressure. If there's not, I would do a spinal tap. But certainly it's not at the top of my list of what I'm going to do for this fellow in the emergency room. Okay, so let's talk about this particular patient now in terms of what we need to know in terms of DTs. He obviously has a withdrawal syndrome from alcohol. Now this patient is easy. The question tells you he has chronic alcoholism, and they give you the classic presentation of an agitated patient. All the physiologic findings you have here is because of a heightened sympathetic state. All right, they're tachycardic, they're hypertensive, they're tachypneic, they're sweating, they're tremulous. Okay, this is all a sign of a withdrawal state. Now, do you know for sure, if I just took out the words a 64-year-old man, and I take out the words history of chronic alcoholism, do I know that this is a alcohol withdrawal state? No. What does a benzodiazepine withdrawal state look like? Identical. All right? But this is characteristic of a withdrawal state of some hypnotic or sedative type medication. All right? Just think of it. If you're used to being brought down by alcohol, benzodiazepines, or even heroin, narcotics, and you withdraw that, you get this rebound sympathetic response, regardless of what the underlying substance abuse is, if it's a depressant substance. Okay? I just had a patient in the hospital. Patient post-op day 3, after bowel surgery, starts pulling out his Foley catheter, saying he wants to get out of here. He gets very agitated, combative. Now, this was a man that I had known had been drinking a year or two earlier. He had sworn to me, because I was worried that when this guy comes into the hospital, maybe he's been drinking recently, because alcoholics are not the most reliable historians, and I'm going to have to watch for DTs in this fellow. Now, it's post-op day 3, just about the right time. Day 2, day 3, is we're going to start seeing these severe signs after alcohol withdrawal. But he had sworn to me, for whatever that's worth, that he wasn't drinking. And in fact, it doesn't matter if he was drinking or if he was doing what he was actually doing, which was, his wife told me, look in his medicine drawer. I called up his wife. Has he been drinking at home? No, I don't think so, but look in his night table. Sure enough, I open it up, there's a bottle full of lorazepam, a benzodiazepine, and he'd been taking those chronically to calm his nerves before he came into the hospital for surgery, and didn't tell anybody when he came in that he was taking a benzodiazepine. So he had a withdrawal syndrome. My first suspicion was that he actually was drinking until he came to the hospital, but actually he wasn't. He was taking benzodiazepines. And he was having a full-blown DT attack, hypertensive, agitated, pulling out his Foley catheter, thinking people were threatening him, and this was all a benzodiazepine withdrawal. What did I do? I gave him some benzodiazepines, and it calmed things down, and then we would have to taper them off, okay? So these things happen in a post-operative or hospitalized patient also, and it'll be a lot more subtle to make the diagnosis, all right? On step 3, they have given a number of times a physician who is brought in as the patient to, say, the coronary care unit with a myocardial infarction, who gets very agitated his second or third day in the hospital. And you say, well, he's in the coronary care unit. Is he throwing an embolus to his head? Is he in heart failure, poor forward flow? Is he having a stroke? the answer was go back, take a history about possible alcohol use. All right? Again, anything that's happening where a patient looks like this after 2 or 3 days in the hospital, acutely, think about what was the patient taking up to the time they got to the hospital. Are they having withdrawal syndrome? And if you didn't take the history, and if you don't think about it, they'll sneak up on you, and all of a sudden you have a very delirious, agitated patient, and you're running around the hospital getting consultations, neurologists, neurosurgeons, CAT scans, spinal tap, and all you need to know is that the patient was using alcohol or some other depressant substance, and you need to treat these delirium tremens. How do we treat it? Well, first we stabilize the patient. We put in intravenous access. We give the patient hydration. Make sure the patient is hemodynamically stable. This patient blood pressure is fine, 130/85. Then I need to treat this hypersympathetic state, and I want to calm the patient down. So I'll give them a short-acting benzodiazepine. If he could take orally and he's not hyper-acute, then I might give it to him orally. More likely, if he's this agitated and combative, I'll give him a couple of milligrams of an intravenous short-acting benzodiazepine, of which there are many. Okay? So the key here is recognizing the diagnosis. Here the question makes it very clear. Then establishing intravenous access, stabilizing the patient, and treating the underlying problem of this hypersympathetic state. Let's say the patient came in like this, but the blood pressure wasn't 130/85, it was 195/120. What would be the drug of choice to treat this patient? This hypersympathetic response, this hyperadrenergic response, I'm going to treat the patient with a beta blocker. Okay? And if I have a very hypersympathetic patient who's very tachycardic, very hypertensive, in this setting, since I know it's a withdrawal state, and the patient's hyperadrenergic, I give an adrenergic blocker. Okay, and that you could give one of many drugs. There are short-acting IV beta blockers as well as oral beta blockers. Okay. Now let's think about what else I would have to think about doing for this patient. We're going to hydrate them. We're going to give them some benzodiazepines. We're going to deplete their magnesium, and we'll give them intravenous thiamine and folic acid. Why is that? Are we concerned about his diet going forward? Are we concerned about that he's nutritionally depleted, and we need to worry about if he's been eating enough fruits and vegetables? Why all of a sudden are we getting interested in nutrition? Why don't we talk to him about eating a good balanced diet instead? Why are we rushing to giving him intravenous thiamine and folic acid? In fact, does he need folic acid right now? No. Acute folate deficiency doesn't really exist. Folate deficiency does have problems associated with it. What is that? Chiefly megaloblastic anemia. Anemia, hypersegmented polys, high MCV, megaloblastic big cells, but that's not an acute problem. All right? Even if I was told he was anemic, I still don't care. I don't need to rush to give him IV folate. What I do need to rush to give him is IV thiamine. Now, why is that? Because of the following. Alcoholics, especially those with chronic alcoholism, who are really heavy drinkers, often a lot of their calories are from their drinking, from their alcohol, from their carbohydrates in the form of their alcohol intake. And they're not eating that much. So they're getting most of their weight from their carbos, and they're not eating a diet that has much thiamine in it. Now what happens is, he's been thiamine deficient maybe for weeks or months. Why will he develop an acute thiamine deficiency here in the hospital? Acute thiamine deficiency in the hospital. Because when he came in, we put the IV access in, and we gave him some glucose. Okay? And this is a common scenario on the boards. Is a patient who comes in, gets intravenous glucose, and now starts becoming hallucinatory once they get to the hospital. Different than this patient. Right? Notice when the symptoms started. Here they exist, and that's why the patient's coming in. If the question tells you a patient comes in usually related to something, to their alcoholism, like an aspiration pneumonia or maybe head trauma, etc., the patient gets some intravenous glucose in the question. The next thing you know, they're wildly confabulating. They're having hallucinations. Okay? That's not necessarily alcohol withdrawal. I would also say, what is the patient's visual ocular movements? Do they have nystagmus? Do they have ophthalmoplegia? Because what am I describing there? Acute hallucinations, ophthalmoplegia, delirium. What's that? That's Wernicke-Korsakoff encephalopathy. That is an acute thiamine deficiency. Let's get back to the question. Why does it happen once he's in the hospital? He hasn't been eating thiamine for years. He's been thiamine deficient for years. Why is he doing me the favor of getting sick right now in the emergency room? Because I gave the patient glucose. the patient might have had a little bit of thiamine still circulating, enough to prevent the Wernicke-Korsakoff encephalopathy. But I give him some glucose, he starts up all those metabolic biochemical cycles that you needed to know for step 1, don't need to know for step 3, and he utilizes whatever little bit of thiamine he had left, he utilizes in those cycles, and now he's truly thiamine deficient. Has no thiamine, and he develops a full-blown acute Wernicke-Korsakoff syndrome. So, beware of that presentation in the hospital. It'll be an alcoholic who comes in who gets intravenous fluids. And they might tell you it's intravenous glucose, but if they get intravenous fluids and then they develop an acute Wernicke-Korsakoff syndrome, it's give thiamine immediately. All right? We discussed here in the syllabus how clonidine can also be helpful. Again, I'd rather use choice 6, a beta blocker, which can be more readily monitored, easier to control in terms of duration, and there's all kinds of different beta blockers we can use, whether it's IV or PO. All right? So in terms of this particular patient, the way I handled it is I assumed he had a withdrawal syndrome based upon not the agitation. That could be that he's drunk. Not because he has a fever. Maybe that's because he's drunk and aspirated. The visual hallucinations made me think something about withdrawal. Visual hallucinations also could be Wernicke's, but they didn't tell me about ophthalmoplegia. They didn't tell me about nystagmus. All right? Remember, the hallucinations can be from DT, can be from Wernicke. In a question with Wernicke, they'll give you nystagmus. All right? The delirium could be the same. One you treat with thiamine, and the other we're going to treat obviously with benzos and beta blockers as needed. Acute schizophrenia, well, acute schizophrenia can happen. It's usually not going to appear for the first time in a 62-year-old. It can appear with agitation in a combative nature. More often, schizophrenia will have auditory rather than visual hallucinations. They'll hear people or gods talking to them maybe, but they're not going to be seeing imaginary monsters as often as they would be hearing auditory hallucinations. Whereas in DTs, the hallucinations are more commonly visual. And there's something we used to call the string sign. We used to go up to a patient and say, here, what color is this string? And they'd look at a camera and say, yellow, no, blue, green, it's green. That's called a positive string sign in an alcoholic patient. In other words, they think something's there's nothing there. All right, they'll tell you about the monkeys crawling on the walls. All right? Okay. Bacterial meningitis in an alcoholic, yes, they are more prone to bacterial infections, alcoholics, and they can have a good reason to have pneumococcal infections elsewhere in the body, like an aspiration. But does this fit classically for meningitis? No. Most meningitis patients, acute bacterial meningitis, do have a fever, but usually there's a change in their mental status that they're getting sleepy or more tired. They will not generally come in with combative and agitated. He has a supple neck. There's nothing here about a rigid neck, nuchal rigidity. And so again, even though bacterial meningitis is worth thinking about, it's not the very highest up on my list. Subdural hematoma, again, something that you should think about in every alcoholic, even without visible signs on the physical of head trauma, because that's something you can't afford to miss. If there's a subdural hematoma and it might start to cause increased intracranial pressure, you better know about that right away, because you might need to relieve that pressure by drilling a burr hole into that person's head and evacuating that clot if it's big enough. All right? And again, they won't tell you an alcoholic who was wildly drunk, fell and hit his head on a curb, has blood dripping out of his skull, has large ecchymoses all over the rest of his body. They don't have to make it very obvious that the patient's had a lot of trauma. Right? Just some hint that the patient's at risk for falling down and having head trauma. So subdural hematoma is worth thinking about in the alcoholics. But again, in this patient, there's a lot of other things to lead me straight to the diagnosis, which is correct, which is DT. DT in its most advanced state can cause not just the hyperexcitability that start with tremors, but think of it, the most extreme kind of tremors gets progressive to seizures, all right? And if you don't treat these patients, delirium tremens will progress, tremens like tremor, will progress to seizures. And if you have a patient with alcohol withdrawal and you don't recognize the diagnosis, they'll get more and more hyperadrenergic to the point that they can have a generalized tonic-clonic seizure. What would I do if that was the question? So they tell you a patient has delirium tremens. They tell you a patient has acute benzo withdrawal, and they're having a seizure, what do? Again, in the acute setting, I'd put an IV in, and I would give a benzodiazepine intravenously. Okay? All right. We talked about the symptoms generally develop anywhere from, say, 12 hours to several days after the last drink or last benzodiazepine pill. So again, suspect it even if they don't give you a history of chronic alcohol or benzodiazepine use. All right. Let's move on to the next question. A 19-year-old white man who was playing rugby 6 hours ago comes to the emergency department complaining of a severe headache for the last 2 hours. For those of you not familiar with rugby, it's a rough sport, okay? Combination football and riot. While playing, he sustained head trauma and had a brief period of loss of consciousness from which he awoke and was his normal self. Most people who play rugby aren't too normal to start with, but he became his normal self. He also started to complain of nausea, vomiting, and weakness of the right side, as well as an inability to walk. He has no other medical problems. Now, is this guy acute? Got to do something right away? If it's CCS, or is it something that I can wait, see him do a test or two, see him again in a week in the office? Obviously, there is something very acute about this patient. All right. So if this was a CCS case, I would immediately start thinking about what I need to do right away, all right? And my whole approach will be different. Now, again, on the prior tape, by the way, on the prior case, I talked about CSA. Obviously, I'm talking about CCS when we're talking about taking step 3. CCS, not CSA. My apologies for the confusion. Let's go on to the physical. Vital signs are temperature of 37.8, blood pressure 120/80, pulse of 88, and the respiratory rate 18. Hey, now those vital signs don't look so bad. So I say now, come back in 2 weeks, take a different approach? No, this is still a very acute patient. Any patient, what makes it so acute? Why am I so excitable about this guy? Loss of consciousness, number 1. Number 2, among people who have loss of consciousness, there's every person you're going to see on the boards, every case that you get on CCS where there's a loss of consciousness, is that going to be a very acute case? If they tell me someone comes to the emergency room because they had a loss of consciousness on the subway, and they tell you that the patient is perfectly normal, never been sick a day in their life, not diabetic, it was very crowded, it was very hot, they were perspiring, and they lost consciousness. Is that acute? Yeah, it might be, but it might just be a vagal episode in a dry patient. So loss of consciousness can be life-threatening, or it can be something that's not so acute. But until proven otherwise, an acute loss of consciousness is something very major, all right? So always make that assumption. And what else do I have in that first paragraph that tells me this is a bad case, that this is a sick, acute situation? He has focal findings, all right? Now, nausea and vomiting, that's so-called nonspecific, but nausea and vomiting after a loss of consciousness right away should make me think what? Okay, remember, a lot of things are nonspecific, don't lead you to any particular diagnosis. But nausea and vomiting after head trauma should make you think of increased intracranial pressure, which is a whole new level of acuity, a whole new level of problem. All right? So, again, nausea and vomiting usually very nonspecific, in this case, very worrisome. And what else is very worrisome in that first paragraph? We've all hit our head. Do we hit our head to the point that we develop focal findings on one side of the body to indicate one specific neurological focus of injury? Of course not. This is a very sick patient, and already from the first paragraph I have head trauma in a patient with possible increased intracranial pressure and causing focal findings. All right? Now, let's go back to the physical. Neurologic exam shows a small ulceration of the left temporal region. All right? So he hit his head over here. His right eye is normal, and his left eye is dilated. And there's a right hemiplegia. Or obviously now this is a very sick patient. Now we're not thinking that this is something we could handle in slow time. But how does this neurologic information fit? The remainder of the physical is unremarkable. Let's think about what this patient has. Head trauma, increased intracranial pressure probably, and focal findings. Trauma over the left temporal area. What do you think has happened? He probably has a hematoma. Can you tell right away whether it's epidural or subdural? No, not necessarily, and you'll need a CAT scan. But you know from the anatomy, and I don't expect you to remember too much neuroanatomy, but this does make sense. If you have left temporal lobe and a right-sided motor weakness, does that make sense? Contralateral side? Yes, it does. Can it have contralateral hemiplegia and a focal, focal ipsilateral eye findings? Yes. All right, ipsilateral oculomotor nerve is being compressed, and there's parenchyma on the brain on the left temporal region affecting right-sided movement. All right, so that makes perfect anatomic sense, and it makes perfect anatomic sense with what I'm told in the question. That's the left temporal region. Now, remember that there's two kinds of head trauma you could get causing hematomas in terms of position. You could, when you hit your head, the trauma could be on the area that you hit. Okay, that's called a coup injury. All right, my head hits. If this is my head, this is my nose. All right, and I hit my head left side. The trauma could be right on that left side. All right, because my brain smashed into my skull, or it can be that my brain hits here, and then this is the brain inside my skull. This is my skull. So my brain could do that against the skull, and then I'll have my left temporal lesion like this guy had. Or my brain might do this and cause some trauma maybe on this side, but the bigger trauma as it bounces off this side and then hits the right side against the right side skull is called contra-coup, the other side. So if I told you this patient had diffuse lacerations on his head and it was witnessed that he fell on the left side, or let's say the biggest laceration is on the left side, or it's witnessed that he fell on the left side, and they tell you, though, that it is a right eye finding and a left hemiplegia, is that inconsistent with this story? No. It's just this guy has not the primary injury where his brain initially hit, but where the brain rebounded against the other side. And in that case, it would be the right temporal region that has the major trauma, that has the hematoma, and it'll be the right side of the brain causing right oculomotor nerve compression, right? And then the right eye will be affected, and a left hemiplegia. So remember, don't get fooled by what side the injury is. You can have a coup or a contra-coup injury. Okay. So, we have a mechanism of injury. We know what the injury is based upon his neurological findings. What will be the first step in this patient? Well, if you say put an IV in, I can't fault you for that. Anytime you have an unstable patient, putting an IV can hurt, if this was a CCS question. Well, if they said put an IV in before you send them to CAT scan, I would say that's a good idea. Think about it. The guy came in, he had a loss of consciousness, had major hemiplegia. Are you going to send this guy off to CAT scan and laying there without any access? Let's say he has a cardiac arrest in CAT scan. Let's say he herniates in CAT scan. You're going to run there and he has no access? Sure, put it in IV access. All right. I'd say if this was CCS, put in IV access, it would be +3 or +5. If you did CAT scan first, the board would say, you know what, you missed something. It's the right thing to do, but you missed something. Maybe they'll even take off a point. Maybe. All right. They don't tell us how they score these things. But again, they do want you to think of acute management. You need to do your ABCs. All right. Airway, breathing, and circulation. All right. And circulation is the intravenous access. Okay. So I got the IV and I'm giving him some fluids. Now what do I want? What test? Spinal tap? Lumbar puncture. How many points do I lose on my -1, -3, -5 scale? -10. All right. Now put a needle into his. What do you think is going to happen if I puncture his dural space in the lumbosacral spinal canal? I draw some fluid out. What's going to come out with that fluid? His brain. Okay. You could suck out through that little 21 gauge trocar. You're going to suck out his entire brain. Have it in your hand. All right. Because there's increased intracranial pressure. Am I exaggerating? Yeah, a little bit. All right. You can't do brain extraction through the lumbosacral spinal canal, but you get the message. If you have increased intracranial pressure, don't suck out the brain with the needle, all right? You want to do the CAT scan, make sure that you don't have a mass lesion in the form of blood. And clearly, in this case, there's a mass lesion with blood. So you're going to do the CAT scan, and then the CAT scan is going to show you in this particular case, he has a hematoma in the left temporal area. Which artery, for those of you neuroanatomy junkies, which artery are we talking about? The middle meningeal is the artery that's most prone to tearing and bleeding. All right. So now we have this guy, we find our anatomic lesion, and we're told that it has convex, let's say this is in the question, they say CAT scan is done and reveals the following. Convex hyperdensity between the brain and the skull, consistent with an acute epidural hematoma. The USMLE might not be so generous and say consistent with an acute epidural hematoma. They'll assume you know what that means if it's between the brain and the skull. A midline shift to the right is seen. All right, does that surprise you? Here's the left side of the brain. You got this big hematoma pushing the right side of the brain over. Along the way, it's compressing the left oculomotor nerve. Along the way, it's compressing those regions that are going to give me my contralateral hemiplegia. All right? What are the key issues in this case? Head trauma, loss of consciousness with evidence of increased intracranial pressure and focal neurologic findings. Establish hemodynamic stability, which this patient has, but put in an IV, and then figure out where the lesion is with a CAT scan. Do you need IV contrast in this situation? No. You could get this guy on and off the CT table within 5 minutes, all right, and have a diagnosis. What do you do with this patient next? This is, let's say, a CCS question. What do you do with this patient now? ER. Start intravenous meperidine for pain control. Start intravenous Valium for seizure, intravenous Valium, they would call it diazepam, obviously, for seizure prevention. Start intravenous phenobarbital or Dilantin for seizure prevention. Arrange a neurosurgical consultation. Prescribe low doses of acetaminophen. Answer? Yeah, you might want to give him some if he's awake and alert and having pain. I think about meperidine, Demerol? Probably not. I don't want to make this guy's mental status change anymore. So that's absolutely wrong. I'm not going to give him anything that's going to change his mental status and confuse my clinical assessment. Obviously, what I'm going to do is call the neurosurgeon. Okay? Then the CCS tells you the neurosurgical consultation is called. Gee, thanks. That's nice. I called him and I know it's called. Where are they? Where are they? I'm waiting. 5 minutes pass by, 10 minutes pass by. You're losing points as the clock is ticking. All right? What do you do next? Neurosurgical consultation is called, and you're sitting there staring at the screen while you're taking the exam. What do you do next? All right, so now you got to think about, till my neurosurgeon comes to rescue me, I need to do something. What do I need to address in this patient? Hemodynamically stable, so I can't stall by giving more fluid and more fluid. I know all about fluids. I know all about cardiac resuscitation, but it's not going to help me here. What do I need to start addressing? The cerebral edema, the increased intracranial pressure, and the hematoma. All right? I want to address something to reduce the intracranial pressure. What do I do for that? I want to, through my intravenous, give mannitol. How does mannitol work? Does it go to the brain and dissolve clot? No. What is mannitol? It's an osmotic diuretic. Okay, if I give it intravenously, it's an osmotic diuretic. I decrease intravascular volume, take some fluid out of the brain, very simple conceptually, and reduce some of the swelling. All right. If I give mannitol orally, it works as a cathartic. Right. Mannitol is just an osmotic substance that works as either a diuretic or cathartic, depending on what route you give it. So here I'm giving it intravenously to decrease the intracranial pressure. What else can I do to decrease intracranial pressure? If you said hyperventilate, I wonder actually if CCS would recognize as a choice. Hyperventilate the patient. They would probably say, does not recognize this command. What do you want to do? I would probably have to intubate the patient. Prepare patient for mechanical ventilation, and patient is intubated. Question says, what do you do now? You say, then they'll say, what controls would you like on the ventilator? You'll say, you'll give them some indication. All right. Then step 3, you're going to be seeing intensive care unit patients during an internship. They expect you to know basic management of respirators. I would say that I would, at this point, maybe they'll accept hyperventilation. Increase the respiratory rate or increase the tidal volume enough to drop the PCO2. All right. Lowering PCO2 causes CNS vasoconstriction, reducing the edema. Okay. And remember, this area is not getting great flow because vessels are being compressed. So the other thing I want to do is make sure that there's an adequate perfusion pressure. All right, I got to be careful. I'm giving mannitol. What's going to do to my blood pressure? Drop it. Right? Do I want this guy's blood pressure to be 75 systolic? No, he won't have adequate cerebral perfusion. So a lot of things you got to juggle here. It all comes down to Increased intracranial pressure. What do I do? All right? Mannitol, hyperventilate the patient. Steroids, never the first or second thing you do. It's very debatable whether that helps at all. Okay? I would start with mannitol because that doesn't involve intubating the patient. All right? Can I hyperventilate the patient without intubating the patient? No. And intubating the patient is a fairly big deal. I'll do it, obviously, if the patient has progressive neurologic signs in front of me. I'll obviously do it if the patient is losing consciousness in front of me. But otherwise, I shoot the mannitol first, see if that works. Then I will intubate the patient, hyperventilate the patient. Neurosurgeon arrives on the scene. All right? Now what are you going to do? Now, on step 3, they're not going to ask you, tell the neurosurgeon to drill a hole in the patient's brain to relieve the pressure in the skull. You don't want to drill into the brain very much. Okay? The answer is, you're not going to be asked to do that, but if you're given a choice, where do you want, the neurosurgeon arrives and asks for instructions about triage. Neurosurgeon is asking you what you want to do with the patient. Where does the patient go from here? You can send the patient anywhere. You send them to your home. You can send them to McDonald's. You can send them to the morgue. It's easy to get them to the morgue from here. All right? What are you going to do? Admit to intensive care unit. All right? These patients are obviously going to be monitored very closely. You're not going to be asked to, they're not going to say, hand me the drill. Don't type in, hand me the drill. You're not expected to do neurosurgical procedures. You need to know, you need to recognize when you need to call your neighborhood neurosurgeon. They're not going to ask you to do complex procedures. Okay. What are the other possibilities that we discuss here in the syllabus? Concussion. What is concussion? This guy have a concussion? Well, he has a lot more than a concussion, right? Concussion, absolute wrong answer. They say, what's the likely diagnosis based just on the history and physical? And you're given subarachnoid hemorrhage, concussion, contusion, meningitis, or stroke. All you could say is it's probably a hematoma of some sort. All right? Is this a concussion? What is the diagnosis of concussion based upon? Do you need a CAT scan to make the diagnosis of concussion? We usually do it to make sure it's not something more than a concussion. But what is the clinical history you'll get to make a diagnosis of concussion? Head trauma, probably a couple of seconds, minutes, probably not hours, of loss of consciousness, accompanied with what other mental status change? Some amnesia, usually for the event and a few moments before it, and maybe even for some longer period of time. That's retrograde amnesia, right? You forget what happened before the event. You don't forget what's happening after the event, right? Retrograde amnesia. Okay, that's a concussion. And if you scan, and the patient, will they have any focal neurologic findings with a concussion? No. Okay? You have focal neurologic findings, concussion will be the wrong answer. What's the next step after concussion in terms of severity? From head trauma to I banged my head and it hurts and I'm fine, to head trauma that's visible with local trauma, to a loss of consciousness, with some retrograde amnesia, which can still be a concussion. What's the next level of injury? Contusion, which is, again, head trauma, loss of consciousness, again, not for hours or days, for some relatively short period of time, amnesia, usually, but not always, absence of focal neurologic findings, and now CAT scan will show some evidence of brain trauma. Okay? Maybe even some blood, but not to the point that there's a hematoma. Right? Some edema, some changes in the brain parenchyma. That's a contusion. Most of those, the vast majority of those, we monitor and don't need to do anything else. And beyond the contusion, we could have what this patient has, is that they actually rupture a vessel, typically a branch of the middle meningeal artery, and we have a hematoma, and then I have to think about, is this patient going to develop increased intracranial pressure and focal neurologic findings? If they do, and they don't respond very promptly to my mannitol hyperventilation, I need to relieve that pressure by having the neurosurgeon put in a hole to relieve the pressure. Okay. Subarachnoid hemorrhage. Does subarachnoid hemorrhage present like this in the middle of activity, loss of consciousness with focal findings? Usually not. All right. Usually the presentation is one of headache, or headache, quote, the worst headache of my life, followed by loss of consciousness. But you might not have the history of headache. The patients may have focal findings, but you're going to have evidence on the subarachnoid hemorrhage. The question will give you evidence of arachnoid irritation. All right. Patient might have some photophobia. Patient might have a stiff neck. All right, nuchal rigidity, that suggests to me subarachnoid hemorrhage. Okay? But again, this is clearly a traumatic event. Does trauma precede most cases of subarachnoid hemorrhage? No. They're spontaneous, or they'll give you a history of hypertension in the past. Okay? That's a subarachnoid hemorrhage. Okay? How do you make the diagnosis of subarachnoid hemorrhage? You'll scan the patient, all right, and it can give you the diagnosis. If it doesn't show enough blood in the subarachnoid space to make the diagnosis, and you still suspect the diagnosis of subarachnoid hemorrhage, what's your next step? Lumbar puncture. You've ruled out a mass pressure effect. Now you could do your spinal tap, and if on a subarachnoid hemorrhage, you should see some, at least xanthochromia, evidence of red blood cell breakdown, if not actual red blood cells. Okay?